forward to Dr. Patel, I think is first up. Bevan, are you there?
Morning, Prof. Yeah, I'm here.
Good morning. Bevan, I hope you're well. So we're going to do the Journal Club this morning, and I think you're first up to give your presentation.
Thanks, Prof. I'm just going to share my screen. Can we see the screen?
Fantastic. You can maximize the picture if you'd like.
There we go. Thank you. Morning, everyone. My name is Bhavin. I'm going to be talking about an article from the BJUI titled "Ultrasound Guidance Can Be Used Safely for Renal Tract Dilatation During Percutaneous Nephrolithotomy." It's a prospective cohort study, and the study population is patients undergoing PCNL between July 2015 and March 2018 at the Tertiary Referral Center for Stone Disease. The objective was to compare clinical outcomes in patients who underwent PCNL with renal tract dilatation performed under fluoroscopic guidance versus renal tract dilatation done under ultrasound guidance. It's likely to be the only study of this sort comparing fluoroscopy and ultrasonography guided dilatation. The procedure was standardized, and you can have a look at the article itself and see the details into it. And it was performed by two surgeons only for this series. So they enrolled about 291 patients who were requiring PCNL, of which 115 required fluoroscopic guided renal punctures, and therefore they were excluded from the study, leaving us with 176 patients who required ultrasound guided punctures, of which 38 ended up having fluoroscopic dilatation, and therefore they were taken as a different arm, and those who then went ahead with ultrasound guided tract dilatation were 138. During those tract dilatations, 131 patients actually had a successful ultrasound guided dilatation. Basically, what this involved was that from the start to getting access into the kidney, no fluoroscopy was used. You use the ultrasound to see where your balloon is, where your sheath is, and then you proceed with the nephroscope after you confirm your placement of the sheath. And the surgical outcomes were sort of fluoroscopic versus ultrasound guidance was used for renal tract dilatation. There was no significant statistical significance in terms of stone clearance when you're comparing both of them, in terms of complications, in terms of blood loss when you were comparing both of them. And what the article also mentions is that there's a 5-unit increase in BMI, then you had 30% greater odds of increasingly severe Clevin-Dindal complications, and a 5-millimeter decrease in the preoperative stone burden was associated with 20% greater odds of stone-free status. In conclusion, they concluded that compared to using fluoroscopy, this study demonstrates that the ultrasound-guided dilatations can be safely performed without higher complication or bleeding rates. What they set out to do. What are the benefits of ultrasound?
Sorry to interrupt, Bevan. Can I just ask you to speak quite clearly? Just struggling to hear a little bit.
All right. Can you hear me better now?
Yes.
All right. I'm going to try and raise my voice a bit. So the benefits of ultrasonography for PCNL over fluoroscopy is that during pelvicolegial access, it allows the surgeon to distinguish between the kidney and the surrounding structures. You get better posterior colegial access more than the fluoroscopy when you're using ultrasound, and Doppler ultrasonography sort of gives you the added advantage of identifying vessels and therefore reduce bleeding. They also said that there is reduced radiation exposure for the patient and the provider, and this cost saving much cheaper compared to the fluoroscopy. And with ultrasound guided procedure, it's faster than the fluoroscopy guided procedure. Limitations of this study is that the decision to conduct dilatation with fluoroscopic or ultrasound guided was not necessarily stochastic, and in that the surgeons in this study gained expertise in use of ultrasonography during all aspects of PCNL. There was no account for surgeons' bias in choosing one dilatation method over the other, and they basically must have perceived some previous difficulties for a given patient, especially patients who had higher BMIs and and therefore more sort of adipose tissue and poor vision of the kidneys. Based on that, they would have probably started off with a fluoroscopic dilatation then. And then the last was potential lack of statistical power, given that there's a small size of fluoroscopic dilatations. That's my general review. Thanks, Rob.
Thank you very much, Bavin. Interesting study, which I think gives further confirmatory evidence to the increasing role and confidence that endourologists have in using that modality to do the puncture. I just wonder if Lisa Kesner is perhaps there to comment on this particular study. I know it's been her preferred method now for some time. And if Lisa's not there...
Hi, good morning, John. Can you hear me?
Yes, hi, Lisa.
Yeah, no, it's a very interesting study. I haven't really got to the point of doing my dilatations ultrasonography. I just, even though we have that amazing ultrasound machine, it's just not something that I'm comfortable with. And as the department continues to challenge me on every aspect of my PCL, I have no doubt that maybe I'll start doing that soon too. But I definitely do think it has a huge amount of benefits for gaining access. One of the added benefits is if you work in a training institution, your registrars who screen too much won't give you cancer because they can't kill you with an ultrasound. But I still think one of the greatest benefits is to see other organs, because obviously your CT doesn't predict how the patient's organs are going to be when you're actually doing the PIC, because your position is different. You know, they're not lying completely flat supine. Even if you're doing supine, you are changing the position by putting a roll underneath them. The other benefit, which actually the little wizard Desai has mentioned before, and that was one of the reasons I thought ultrasound would be great, is that when you do fluoroscopic PICs, you're often limited by your access, how you can approach the calyx, whereas with an ultrasound, you can use it to go exactly on the axis of the calyx. And that is useful if you're doing an upper or a lower pole PIC, because in the middle of the kidney, the axis of the calyces are along that line, whereas top and bottom, they're facing vertically, not the horizontal kind of plane that you're used to when you're doing fluoroscopic PICs. So I can definitely recommend it. If you can't do it, you should learn it. It's very useful.
Lisa, can I just clarify? I'm astounded that they did the dilatation with ultrasound. I can't see how that can be safely performed.
I don't know, but there was a very large study from China published, gosh, it's a few years now, where they had a large series, over 100 patients, where they did a completely ultrasound PIC. So they did the patient in the lateral position, and they did a completely ultrasound PIC and dilatation. And obviously that's the problem if you want to do the patient completely flank, is that you can't really use screening. And I don't know how they did it, but it does seem possible. I'm not sure how they accomplished that, especially in larger patients, because definitely the larger BMI patients are a hell of a problem. Even with a very good ultrasound machine, your vision is not as good as with a slender patient. So I could think, you know, there are some people that do PCNL who literally only screen once to get their depth, and then they actually dilate based on the depth of their PIC. So once they've done a single dilatation with fluoroscopy, they know how deep the calyx is, and then they will dilate based on that depth. So obviously once you're in the system, you will see contrast or fluid flash back through your sheath. So that also does tell you that you're in the right place, but it's not something that I've practiced. I still need to use my fluoroscopy to tell me how deep I am, just so I feel happy.
Yeah. Lisa, thanks for your contribution. I wonder if we can just quickly go to Dr. Kent Flukas. He's on the call. Kent, you're our up-and-coming endourologist, and you've had the opportunity to learn or to get exposure to both fluoroscopic and ultrasound techniques. Which do you think you're going to take out into independent practice?
Morning, Prof, and everybody else. Yeah, thanks for the question. I must say, having been with Lisa and the wonderful ultrasound machine, it has kind of spoiled us, I think, in terms of using ultrasound. But personally, I find, you know, using a bit of combination seems to work quite nicely as well. Sort of initially using your ultrasound to guide you, because the wonderful thing, of course, is with a guide, you can actually, sometimes if you do it nice, you can actually see your needle actually go onto the stone, actually go to the perfect calyx. And if you just off sometimes, then the ultrasound works quite nicely. The fluoroscopy then works quite nicely to kind of just affirm exactly where you are and the depth that you are exactly. So I think, using a hybrid combination also helps in terms of using less fluoroscopy. In that sense, I think, you should be comfortable in using both. And I can't see the problem with using one to support the other. So yeah, for me personally, I think, and I also quite like triangulation. So um, using the ultrasound initially and then just using the fluoroscopy sort of to confirm that position, yeah, it seems the most comfortable and natural way to go.
And thank you very much. Yes.
May I just add an extra point? I think also it depends on what kind of stones you're dealing with, and for instance, we had a case yesterday where the whole calyx was packed, and in those patients where the whole neck of the calyx is obstructed and you can't actually blow the calyx and you can't get contrast into it, I'm not really sure how you'll get in only with ultrasound, because in those cases, if you get nothing back, but you're sure you aren't, you can feel the stone, we usually put in a tiny amount of contrast, and then you can actually see that you're in the system and it's safe to put your guide wire in, So I think the fluoroscopy is invaluable if you're dealing with complex, difficult perks in patients where the calyces are packed or you've got a full stag where you are struggling to actually confirm that you're in because you can't get any fluid back, especially in that group where you can't dilate calyces well because the whole system is a cast.
Indeed, a very good example, Lisa. Bavin, thanks very much for your contribution. We're going to move to Dr. Nkanyezi Sigaza, one of our urology registrars here in Cape Town. Can I just ask, I'm struggling to find where people would put their hands up if they wanted to speak. Can someone explain that to me?
John, you click on participants, and then at the bottom, it gives you a little blue hand that you can click on. So if you click on at the bottom, there's participants 57. So if you click on that, it then brings a pop-up, and then you have a blue little hand that you can click on.
Okay, maybe because I'm the host, I can't seem to do that, but I'm sure hopefully everyone else can. So we'd like to see some hands if anyone's got questions. Nkanyezi, it's all yours.
Morning, Prof. Morning, everybody. So today we've got presenting the Journal Club, and the article I'll be talking about today is the 10-year mortality disease progression and treatment related side effects in men with localized prostate cancer from a PROTECT-T randomized control trial according to treatment received. So basically in this trial, their objectives was to report outcomes according to treatments received in men who were randomized into treatments, or they had treatments of choice. So there were two cohorts. These patients were patients with localized prostate cancer. The outcome measures were mortality, where patients who passed, they determined the cause of death, and metastases, which was defined as bony mets, visceral mets, or lymph node mets that patients developed after the intervention. Disease progression, which was metastases, clinical progression from a lower stage to T stage 3 or 4, long-term use of ADT, ureteric obstruction, the formation of fistulas, or the need for long-term care.
Good morning. What happened to your chap? What is it?
Sorry? Huh? Okay. Sorry. And health-related quality of life impact. This was measured as these health-related quality of life impacts were urinary incontinence, nocturia, potency, and blood in the stool. So patients for this study was an interventional study that was conducted in the UK in one of the medical centers there. Patients basically were patients with localized prostate cancer that were recruited and volunteered to be in the study. From the patients, there were two cohorts, patients who agreed to be randomized to a treatment intervention, and some patients decided not to be randomized. The patients who were in the randomized group, there were about 1,600, and the patients who chose their treatment was 997. The interventions included active monitoring of patients, basically patients who decided to be in this group or who were randomized to this group had PSAs done every 3 months for 1 year, and then 6 to 12 months then after. If the PSA increased by more than 50% in 12 months, active treatment in terms of radical treatment was done for the patients. The second intervention was a radical prostatectomy. And then the third one was radiotherapy, which also included brachytherapy. The health-related quality of life impact was assessed using patient-reported outcome measures. These results were then assessed, and patients were followed up for 10 years. This table basically shows the basic characteristics of the patients in the randomized and the treatment group. Of note is that patients with higher Gleason scores or higher stages opted to be in the radical group, where they got surgical treatment or radiotherapy. This was basically due to a selection bias, where patients were kind of guided by clinicians, especially in the treatment choice group, in terms of what treatment to have or what option intervention to have. But basically, the basic characteristics of both the patients of both the groups were initially similar. This table is just a table I put together just to summarize the most important clinical outcomes. So the metastatic disease, they found that patients with active monitoring had increased metastatic disease. They also had higher chances of disease progression. They also were found to be ultimately put on a long-term ADT. And although death in itself was low, and consistent with chance, they found that patients who are on active monitoring were more likely to die from prostate cancer specific death. So basically, morbidity and mortality was more higher in the active monitoring group. Another outcome, which was urinary incontinence, they found that patients who had radical prostatectomy were more likely to develop urinary incontinence. They found that about 55% of the patients who had radical prostatectomy at 6 months were incontinent. And over time, it settled down to about 20% and remained stable. But also of note was that patients on active monitoring also later on developed urinary incontinence, but this was basically due to normal aging pathology. Nocturia was also found to be one of the outcomes. It was found to be high in patients who had radiotherapy. They found that about 65% of patients who had radiotherapy developed nocturia. Basically, they defined this nocturia as waking up at night more than 2 times to urinate. And once again, the nocturia kind of increased with time, in all the treatment groups, which is also due to normal aging pathology. Potency, basically about 18% of patients who underwent radiotherapy reported normal potency. And only 5% who underwent radical prostatectomy reported normal potency. So there was a basically decrease in sexual function in patients who underwent radical therapy. This did improve over 2 years, but still patients who were actively monitored had the best sexual function. And patients who had radiotherapy were found to develop blood in their stool, about 5% of those patients, and that remains stable. So basically these results showed that active monitoring active monitoring avoids the adverse effects of radical therapy at a trade-off of decreased risk of metastatic disease progression, and length of life. The limitations of the study were basically selection bias. As I alluded to before, that patients with higher risk disease tend to have radical therapy. And this was more in the patients who had treatment choice group, as these patients were coached by doctors to select a treatment option based on the prognostic factors. And another limitation they had was that over time, there was changes in how patients in active management group were managed. So patients with elevated PSA are now receiving MRIs and fusion-guided biopsies, which these patients did not receive. So therefore, this could have been a reason why patients in the active group, although did have less side effects in terms of health outcomes, but had more morbidities because high risk lesions were not detected and patients were not treated. Another limitation they thought was that over time there's an improvement in prostate cancer treatment. So this improvement in terms of radical treatment could have actually affected their results. And it seemed that patients with radical treatment did better, but only because the techniques and management of patients with prostate cancers are being improved. So basically the conclusion was that surgery and radiotherapy reduce mets and progression, but they impact severely on sexual function, urinary symptoms, and bowel symptoms. Radical treatment is associated with lower prostate cancer mortality, but this was also obviously needs to be taken in the context of a couple of issues that they had with bias. Thank you.
And Kanyezi, thank you very much. And I wonder if you could just put up that slide with that you constructed. It's most helpful to focus on a few points. Our uro-oncology colleague, Dr. Samkele Salukuzana, I think is on the call. I wonder if he's got any comments to make about this important study.
Good morning, Prof. Good morning, everyone.
Is your camera working this morning, or are you still in your pajamas, Dr. Sam?
No, not in my best attire.
That's fine. We'll enjoy your voice then.
Thanks so much to Sagasa for a great talk and really discussing such landmark trial in basically how prostate cancer is recently, well, how it's managed in these days. And just a few comments on the study. One of the things that I'd like to mention is that the study actually had a lot of patients that were in the intermediate risk category. And the analysis was probably mostly based on that. And it was also PSA based, how patients were screened. And what Sagasa actually mentioned is quite true, that the patients in active monitoring group were actually not sort of selected based on the strict criteria of active surveillance in these patients. So some of them were not even, so basically mainly based on PSA values. So the one important thing on the effects or on the outcomes of the study was what Sagasa mentioned, that actual fact, the mortality was actually not statistically significant different amongst the different groups at 10 years. But the only differences were just light that in the patients were actually intermediate group looking at sub-analysis, they had a slightly increased risk of getting mets. I think it was about, well, the low risk patients are just less than 3%, and the intermediate risk were just above 3%. You know, the risk was really for increased risk of getting mets. But again, as she echoed, that the mortality was really not different amongst the groups. And very importantly, the study highlights the importance of having an MDT meeting. You know, now that we sort of having strict criteria for active surveillance, that we should not really over-treat patients and rather super select, because we've seen with the 10-year data that, the mortality is not really different. It even would be better, in fact, even up to 15 years in patients who are properly selected for active surveillance rather than active monitoring, which is not really the strict active surveillance criteria that was used.
Sam, thank you very much. I'm looking around to see if any other senior colleagues. I see we've got Professor Mutambirwa. I'm wondering if he has any comments to make. Very nice to have you with us. I think this table that you've constructed is very helpful in some ways, but also slightly misleading in Kanyezi. And the figures that I've got, this is an important trial. 80,000 men were screened with PSA. 2,500 turned out to have localized prostate cancer. Of those 2,500, 1,500 agreed to be randomized. And there were roughly 500 apiece, radiotherapy, surgery, or active monitoring. And I think Sam's made the very important point that active monitoring is a very poor cousin compared with what we have in terms of active surveillance. So presumably men might have fallen through the cracks because of the active monitoring not being up to scratch really in terms of modern active surveillance programs. So I think that's the first thing, that there may be excess deaths there. But I think perhaps the most important thing is that you've got these 2,500 men who've got, or rather 1,500 men, but in that group at 10 years, there were only 17 deaths. So it's a very tiny number of men that had prostate cancer specific deaths. So to say that the deaths were high in the active monitoring group, one's just talking about one or two more patients. So I think one has to be cautious about over-interpreting that. However, what the trial did tell us is that radiotherapy or prostatectomy, as we well know, are both good options for men with localized prostate cancer. And it does then come down to the symptoms or the side effects rather of the treatment. And Kanyezi, I didn't get the figures there. In terms of potency, radiotherapy versus surgery, what were the sort of figures there? And how much worse was the urine incontinence in the prostatectomy group? Do you have those figures?
Yes, Prof, I do. So in terms of urinary incontinence, according to the study, urinary incontinence was more higher in patients with radical prostatectomy. At 6 months, they found that 55% of patients experienced urinary incontinence. This was measured by basically patients using pads. So they found that about 55% of the patients use pads at 6 months, but then throughout time, it decreased to about 20%. And at 3 years, 20% of the patients who underwent radical prostatectomy had urinary incontinence. And in terms of potency, they said that about 18% of men who had radiotherapy recorded that they had problems with their potency. And about 18% radiotherapy and 5% prostatectomy. Those patients were patients who had normal potency. Then their potency improved, and about 30% of men who underwent radiotherapy had then reported normal potency, and then 15% of men who underwent radical prostatectomy had normal potency. So to some degree, most of the patients who had radical treatment had decreased potency.
Okay, thank you. That actually explains it very nicely. Thank you, Kanyezi. I think we're coming to the end of that. I don't see any questions, so thanks for your contribution. We're going to move to Dr. Cleve Oppel next, who's got a British Journal of Urology paper. Welcome, Cleve. Are you there?
Prof. Mutambirwa has got his hand up.
I beg your pardon. Shinga, it'd be lovely to hear what you have to say.
Oh, so yeah, morning. Great presentation, and I really think that we're underutilizing active surveillance and active rather rushing to treatment. But Just to put it in context, Larry Klotz just released some of the data from obviously the guru of active surveillance. And he released some of his data about patients with intermediate risk prostate cancer rather than on active monitoring. And at 15 years, he actually said that up to 30% of the guys were getting metastases. So I think we have to balance that. And also when you consider that we in Africa probably have a slightly higher risk of having BRCA2 mutations, I think we have to be a little bit careful with some of our patients. But low-risk patients, I really think we're underutilizing it at the moment. But this is actually a really excellent modality of treatment for most of our patients, I think, at least 50%.
Thank you for that contribution, and those provisos are well taken. Thank you, Shingai. Let's move forward now to Dr. Oppel. Dr. Oppel is our resident Liverpool supporter in the department.
Thank you for that introduction, Prof. You got the club wrong, but the sport correct. Yes, thank you, everyone. Morning. Today, my article, which I'll be discussing, is the direct comparison of multiparametric MRI results with the final histopathology results in patients who had previous...
Lee, could you maximize your screen, please, and try and speak quite clearly and loudly?
Apologies for that, Prof. Is the sound a bit better? Let me just check something.
Thank you. It's good.
Okay, let me just confirm that we're on maximum settings. Okay.
No, that's good. I can see it now.
Okay, good. Yeah, so it's basically, let me just move into our objectives of the study. So the objectives or the aims there were two aims primarily. What they wanted to do was they wanted to compare the multiparametric MRI PI-RADS scores with the final histopathology radical prostatectomy specimen Gleason score and see if they correlated. And the secondary or the other aim was to evaluate the different prostate biopsy modalities. They looked at fusion MRI, fusion guided biopsy, systematic template 12-core biopsy, and a combination of those two to see which of these sort of biopsy techniques is the best for risk stratifying patients. So the fusion guided biopsy was by a transperineal approach, and the systematic 12-core template biopsy was transperineally. Fusion guided biopsy, sorry, was transrectally. As you can see from these results here, the MRI fusion guided biopsy detected prostate cancer in 90% of the cases. Systematic biopsy fared slightly weaker, only detecting cancer in 68% of those cases. Of the tumors that were missed, the systematic biopsy missed about 33 tumors, of which 9, I think it was 9 or 10 were clinically significant tumors with a Gleason score of 7 or higher. When you look at the concordance with the different biopsy modalities and the final radical prostatectomy histopathology specimen, what you can see here is that the systematic biopsy was quite weak, with 56% comparison with the final specimen, and 46% of the Gleason scores which were found on the systematic biopsy pre-op were upgraded subsequently after radical prostatectomy. When combining a systematic biopsy with obviously a fusion-guided prostate biopsy, the concordance was a lot better with the final histopathology specimen, about 78%. Only 19% of those specimens being upgraded on final radical P specimen histology. Looking at the MRI, as you can imagine, with increasing PI-RADS score, the Gleason scores were a bit, obviously a bit more higher, more aggressive. But still, even with the PI-RADS 2 and 3 lesions, the final radical prostatectomy specimen did pick up clinically significant cancer in almost 50% and more of some of those cases. The total amount of MRI identified lesions were 175 lesions in these 105 patients of the study, with sensitivity, specificity, NPV, and PPV being 84, 85, 94%, and 60% respectively. For all types of cancer detected lesions. The other issue with the MRI is that 58% of the lesions were found in the anterior zone of the prostate, which is difficult to reach via a transrectal systematic biopsy on its own. Index tumors were identified in 87% of the MRIs, indicating that quite a large volume of index or significant tumors were actually missed on the MRI. And funnily enough, the final histopathology specimen identified that of those sort of 13% of missed tumors, they all had a sort of cribriform pattern, which we know is at least a Gleason 4. So definitely significant tumors were missed even on the multiparametric MRI. Two major pitfalls which could be identified from this study is that the MRIs were retrospectively evaluated by only one urologist who was not blinded to the evidence of the final histopathology report. As you can imagine, this led to detection bias and over-detection of tumors which weren't sort of there before. And the proof is in the fact that 15 more tumor suspicious lesions were detected when retrospectively reviewed by the uroradiologist. The other pitfall is that the same urologist who had to perform the targeted MRI fusion-guided biopsies was also the same one that did the systematic prostate biopsies. The problem here is that knowledge of the location based on MRI findings definitely influenced needle placement during systematic biopsy. So even the fact that the systematic biopsy did fare poorly compared to the MRI fusion-guided biopsy, those results were still elevated. So it's even probably worse. What you can conclude from the study is that fusion biopsy of tumor suspicious lesions on MRI is associated with better tumor prediction according to the final histopathology report, as well as a high detection of clinically significant prostate cancer. Although, as we could tell, a lot of the suspicious lesions were actually missed on MRI, which was done before the time, and prostate cancer is a multifocal disease. Therefore, you do still need to perform a sort of systematic 12-core prostate biopsy. So the take-home message from this study is that a combination of doing both biopsy methods represents the best approach in order to predict the final tumor grading in prostate cancer patients. Thank you.
Thank you very much, Cleve. Very nicely summarized. I wonder if I could bring my colleague Justin Howlett in here. He is our resident peritoneal and fusion biopsy expert, and perhaps if there are any other colleagues around the country that have some experience with doing fusions, would we welcome their comments. Justin, I see you on the line there. What do you think of this trial?
Yeah, so a very interesting trial. I think that all along we've known that MRI misses about 15% of significant cancers, but I think because 85% is such a good number, people have been putting all their store on MRI and saying that that's kind of gospel. And I don't know if remembers the old GPS trackers that it used to say that you're tracking 2 satellites and you're within 15 meters, and then you get to a better signal and it's tracking 3 satellites, you're accurate within 10 meters, and 4 satellites, you're accurate within 1 meter, and then they get the more satellites you get, the more accurate your position is. And I think it's similar with kind of prostate cancer. You got to take into account the PSA. You got to take into account the Amico risk classification. You got to take into account the MRI and the systematic biopsy. And the more you do, the more accurate your staging is going to be. So I think that we do accept that MRI and fusion is kind of probably the best way to go. And if you add systematic biopsy as the EAU guidelines recommends, then you're getting pretty close. You are going to, in this study, 19% of significant cancers you're going to miss, but you're not going to overtreat insignificant cancers as well. The other point is that I think what the weakness here is the transrectal approach, because we use a transperineal approach, and certainly it does make it much easier to sample the anterior zone. I'm not sure how easy it is, especially in a big prostate, to get into the anterior fibromuscular stroma transrectally. So those are my comments.
Justin, can I ask you, are you compelled enough by the data here presented by Cleve that systematic in addition to fusion is required? I know that there are colleagues in town who have given up doing systematic. They say you get the answers simply by doing the targeted fusion biopsy. And Cleve, just remind us the extent to which the combination improves simply over the targeted. What were your figures there? Remind us.
If you look at this slide, Prof, a targeted biopsy alone was upgraded still on final report by at least 34%. So the targeted biopsy correlated about in 65% of these, or of these 105 cases, targeted biopsy correlated 65% of the time. Whereas when you combine it with a systematic biopsy, it went close to 80%. So quite a significant increase in.
Okay.
Yeah.
All right. Justin?
So certainly, I think that in your early learning curve, it's useful to do both. The only disadvantage is you have a slightly increased risk of adverse events. I saw a study showing that, if you did just the two or three cores at the region of interest, there's less hematuria and discomfort and so on, versus doing more cores, which we kind of have known, but they've shown it now again. So one has to balance that. But my feeling is if you are on a medical aid and you're going to theatre for a prostate biopsy, you want to get the answer and do a proper job. So I would favor doing both systematic and targeted biopsies.
Perhaps a question for you both. I think you're well aware that the challenges to do a targeted fused biopsy in the state setting presents some challenges. How do you think we're going to overcome those? Because clearly this is a superior option for patients. Any thoughts there?
So we are busy running a study of doing a transperineal ultrasound guided biopsy under local. And when we started off, there wasn't much published about it, but there's been two big trials that have come out recently showing that there's no difference in pain compared to a transrectal biopsy under local. And so we are in the process of doing that. And at present, we've had reasonable results in terms of patients tolerating it. And hopefully, towards the end of the year, we'll be able to report on what our accuracy is compared to fusion under general anesthetic.
Thank you, Justin. That's very inspiring. Okay, let us then, if there are no hands, move to Dr. Omar. Dr. Omar is one of our medical officers, in fact, our one and only medical officer. And Dr. Omar, wonder if you're there.
Yes.
Hi, Aman. Welcome.
Hey. Morning.
Very nice to have you participate. And why don't you go ahead with your talk?
Sure. I'm just opening up my slide. Oops. Cool. Okay, so the article that I read was looking at urinary frequency as a possible overlooked symptom in COVID-19 patients. And the question that they asked was, does SARS-CoV-2 cause a viral cystitis? So it was a case series that was published in the European Association of Urology. It was done at the University of Munich in Munich, Germany. And the reason why they did this is because they noticed an overlap between the classical urinary symptoms and at the time were not yet fully understood symptoms of COVID-19. And they particularly looked at urinary frequency sort of as a presenting symptom. So what sort of sparked the whole sort of investigation or study was that they noticed that there was a case of a patient that was admitted via the emergency department with suspected urinary sepsis. The patient presented with a classic fever, shivering, flank pain, urgency, and increased urinary frequency. With investigations, they obviously did a urine MCNS, which showed no evidence for infection. And then the patient was subsequently discharged, and all patients at the time were getting nasopharyngeal swabs done for COVID. This then flagged positive, and the patient was then admitted to the COVID ward and developed at the later stage fatigue and respiratory symptoms. So what they decided to do was retrospectively and prospectively look at all the patients within the COVID ward at the time. And they looked at the sort of admission notes and looked at the histories and to see if they presented with urinary frequency as a main symptom on presentation. So the time period that they used was 16th March to 13th April. And what they noticed was that 7 out of the 57 men reported urinary frequency sort of as one of the main symptoms as to why they came to hospital at the time. All these patients then were tested for COVID and obviously were confirmed PCR positive on nasopharyngeal swabs and later developed respiratory symptoms, which were detectable on imaging as well. Of note was that on average, micturitions were 13.7 on admission and 11.6 on day 5. In all of these patients, they obviously had to rule out other causes for why urinary frequency would be a symptom that they had. So they ruled out acute renal injury, they ruled out prostatitis, and they did this by doing urine analysis, serum, creatinine, and PSAs, as well as using ultrasounds to look at the prostate size, which showed that they all had mildly enlarged prostates, and there were no signs of residual urine volumes as well as bladder thickening. Of note as well is that all these patients had RNA sort of done on the urine as well, and all of them were negative or were not detected. So as you can see on the table on the side, these are just some of the patient characteristics that they presented. And you can see at the bottom, those are sort of the main symptoms that the patients had on admission, and they were particularly looking at increased urinary frequency, in which 7 patients only presented with that as a symptom. So within the discussion, they wanted to know what was the reason for this higher urinary frequency that they noticed in these patients, and it was quite obviously unclear at the time. The patients obviously had no signs of acute kidney injury, bacterial infection, or prostatitis to explain this, and they suspect that it was due to viral cystitis, and they suspect that it was obviously secondary to COVID. And the reason, the different ways that they were looking at how COVID could affect or cause urinary frequency. So the 3 ways that they looked at were infection via capillaries or viremia that one gets with COVID. They also suspected that infection could happen via the urine itself, because they know that with urothelium, or the cells in the within the bladder, they also have the ACE2 receptor, and we know that COVID sort of enters the cell via attaching to this ACE2 receptor and causing replication within the cells. Another sort of way that they suggest is that cystitis could be secondary to either local or systemic inflammation that happens with COVID, in almost endothelitis type of way. So in conclusion, they basically said that they identified higher urinary frequency as an additional symptom to patients presenting with COVID-19 infection after ruling out acute renal injury or other causes for urinary frequency in the small case of patients, or a small series of patients. They just suggest that symptoms can be misinterpreted as urosepsis, and that we need to know about urinary frequency as a potential sort of symptoms for patients presenting with COVID. And us as urologists, we need to know that this could potentially be COVID if patients present with this and all our sort of workup is negative. But they do, however, say that obviously further research is needed within this topic to understand the molecular mechanisms leading to the urinary frequency. Yeah, so that was essentially what the article showed.
Thanks, Aman, for your contribution. Interesting paper in the sense that it wasn't found in the urine, but it was causing symptoms, and there are reasons for why that might be are intriguing, but I don't think we've quite solved the
I don't think so as well,
problem there. What's your thoughts? Why do you think these patients get these?
I mean, they obviously suggest these 3 ways, and I mean, it's what we see with COVID. With a lot of things. I mean, COVID's still relatively new, and I'm sure there's a lot of studies that are still ongoing, and I'm sure sort of we will see other papers come out soon enough. But I mean, there are various ways. I mean, the viremia makes sense. The ACE2 receptor sort of theory that they mentioned as well makes sense. I mean, it could be, I think, a combination of all those things that could be sort of contributing to it. It's difficult to say.
Yes. I see Professor Mutambiro has his hand up.
Yes.
Hi, Dr. Omar. Excellent talk, excellent talk. Just for the residents out there, remember, association is not always causation, and that's what Dr. Omar has been saying. But a question to you, Dr. Omar, just in your readings, since there's been some discussion about fertility and male fertility and COVID. Did you get any data on? Do you have any data on that?
Unfortunately, I mean, the article itself never mentioned fertility, and I don't think they looked that far sort of into the effects of COVID yet. I haven't in my reading come up about or read about anything with fertility, but it's interesting that you bring it up, and it's something sort of to consider as well. But I'll definitely read up about it and see if there's anything about it.
What have you heard, Shingai? Is there an association?
Oh yeah, they do say that there seems to be an association with fertility, but the data that's out there at the moment, again, it's just this whole thing that association doesn't mean causation. they say that there is a decrease in male fertility when it comes to COVID, but there's so many confounding factors, including the fact that any fever can cause it, because most of the data is only about 3 months. And obviously sperm are only going to be, they travel for 3 months to get to the point where you can actually get the semen analysis. So there is, although they are talking about, because the ACE receptor is a big thing in the testis as well. So it looks like there might be some reasoning behind it, but again, we can't make any firm conclusions at the moment, because even if you have a flu or influenza, you're probably going to have a problem with fertility in the short term as well. So it's just it's more just to press home the fact that we need proper data. We get this is good data, but as I said, but the point is that we need proper information before we can actually make it attribute it to its causation.
100%. I think we're going to move on to Dr. Siyasanga. Thank you, Aman. Dr. Siyasanga Yekani is going to continue the dialogue about COVID and talk about a topic that's very close to all of our hearts.
Thanks, Prof. I'm just going to share my screen. Hi, morning everyone. So the article that I reviewed was a global survey on the impact of COVID-19 on urological services. And as we all know, COVID-19 was first reported in December of 2019 in Wuhan city of China. It was declared a public health emergency in January of 2020 and a pandemic in March of 2020. And as we've all experienced, health services, including urology, have been largely affected. For example, in having to minimize or suspend elective surgeries and in and outpatient services. So the purpose of the study was to study the impact of COVID-19 on urological services on a global perspective. So this study was a cross-sectional web-based survey, which ran from the 30th of March 2020 to the 7th of April 2020. Participants included urological registrars, fellows, consultants, nurse specialists, and advanced practice providers from 6 continents, which were Europe, Asia, America, Australia, New Zealand, and Africa. The questionnaire itself comprised 50 questions that were covering demographics, impact of COVID-19 on healthcare professionals and hospital policy, outpatient clinic, outpatient investigations and procedures, urological surgeries, and attitudes towards COVID-19. It consisted of 1,004 participants. In terms of data collection, synthesis, and statistical analysis, the survey was distributed through the Urology platforms, their website, and on Twitter. And the primary outcome was the degree of reduction in urological services based on geographical location, degree of outbreak, nature and urgency of urological condition. Secondary outcome was the duration of delay in urological services. The demographic data and impact of COVID-19 on healthcare professionals and hospital policy were presented in a descriptive manner, and chi-squared charts were used for comparison between continents, and heat maps for global impact on urological services by location were used. Based on respondents' answers to questions on cut down of services, for example, from 0%, 1 to 20%, 21 to 40%, and so on, mean scores were then calculated for each country from 0 to 100%. Relationship between cut down of urological services and degree of outbreak were presented with bar charts, which I'll be showing shortly. Impact of COVID-19 on urological services by nature and urgency of urological conditions was further analyzed. Outpatient investigations, procedures, and surgeries were categorized as benign, non-urgent, benign, potentially urgent, and malignant. And the results were presented with bar charts, which I'll be showing shortly. Delay of urological services and attitudes of healthcare professional towards the delay, which was defined as more than 8-week wait, were presented in a descriptive manner. So in terms of the impact of COVID-19 on healthcare professional and hospital policy, 78% of hospitals where respondents who work were managing COVID-19 patients. 41% of staff had tested positive, and higher proportions were seen in Europe and North America. 26% had been deployed to COVID services, whether on a voluntary or mandatory basis. Europe cited the highest percentage of personnel shortage, followed by South America and Asia. 47% of healthcare professionals expressed fear of going to work, and there was a low availability of PPE. Of note, there were significant cancellations of MDT meetings, journal clubs, grand rounds, M&M meetings, and X-ray meetings. And then in terms of the impact of COVID-19 by geographical area, the COVID has shown to have a significant impact on the cut down of urological services, including OPD clinics, OPD investigations and procedures and urological services. All types of services appeared to be affected, mostly in North America, South America, South Asia, West Asia, North Africa, West Africa, and some European countries. North Asia had considerable cut down on outpatient clinic appointments, but investigations and procedures and surgery were less affected in these areas. And then in terms of the impact by degree of outbreak, there was overall significant cut down across all types of urological services. Of note, about 81 to 100% cut down of outpatients clinic. Clinic appointments, 37% of the participants, OPD investigations and procedures, about 40% of respondents and urological services, surgical services, and 48% as reported by the respondents. There was the degree of the cut down was increased percentile of cases, with the highest outbreak countries having the most cut downs. Okay, and then in terms of the impact of by nature and urgency of the urological condition, OPD clinics for benign conditions such as BPH, infertility were most affected. Benign and malignant conditions were less affected, and there was a significant cut down on procedures and investigations such as prostate biopsies, but urodynamic studies and uroflowmetry studies were significantly affected. And then in terms of surgeries, surgery for benign conditions were more affected than malignant conditions. And then in terms of delay of urological services, there was a global delay across different types of urological services. 28% noted for OPD appointments, 30% of outpatients investigations and procedures, and about 31% of urological surgeries. Just in terms of the discussion, the survey revealed a substantial disruption in urological care and overall reduction in clinical volume. The greatest cut down was observed in geographical areas with the highest number of cases. The greatest reduction in outpatient clinical volume was observed for benign and non-urgent conditions, but oncological and benign and potentially urgent conditions were also affected. Outpatient procedures such as prostate biopsies, cystoscopies were also delayed in most cases. There was substantial delay in surgical management. The least delay was seen in testicular and bladder cancer, however. There was also a concern that was mentioned in this article of elective surgery in COVID-19 positive patients, and they cited a retrospective cohort study of about 34 asymptomatic patients who had tested positive for COVID-19. There was a reported 44% of patients who then required ICU and 20% of patients who had died. More than a third of the respondents reported COVID-19 positive staff, and about 50% reported fear of going to work and depression. And as said before, there was cancellation of all major professional society meetings in the field, leading to online virtual meetings, and a substantial interruption in ongoing urology education, as noted before. So in terms of limitations of the study, there was strong participation from Asia, Europe, North America, and limited participation from Africa, Australia, and New Zealand. The survey was only conducted in English, and it was conducted in the midst of the pandemic, with many of the urologists deployed to COVID services and were therefore unable to participate. There were also large regional differences in COVID-19 prevalence, even within the individual countries. The study was also done in a limited time of only 9 days for data collection, and they also had a low sample size. That's it. Thank you.
Siyasanga, thank you very much for your contribution, very thorough and comprehensive. The study came out in May, if I got you correct, and it would appear from the figures that 40% of the health workers already had tested positive. Can that be correct? That doesn't quite fit with our figures locally, where we're much further down the track time-wise of the pandemic, and I don't think 40% of our team has been
yeah, no, it seems like it was too much, Prof. I don't know, it seems like it was overestimated. It was from March to April. So our numbers, I don't think were that high at that time. Yeah.
But I think the study is very important in the sense of illustrating the major negative impact on all aspects of our practice, from teaching to training to patient care. And I'm sure we are pretty much all in the same boat nationally. I see Ryan Gounder has put his hand up. Ryan, greetings, morning to you.
Morning, Prof. Yeah, at the same time, you know, while we focus on all the negative aspects, but I think I don't know if anybody's published anything on the positive aspects that COVID brought. I mean, we brought the whole world together in terms of urological information sharing. Even, I mean, those of us preparing for exams were able to connect with Prof. Mutambira, Prof. Mashokwa for tutorials, and even listening to the the American groups and their seminars. So, I mean, as much as, you know, we focus on the negative, I think the positive aspects of and the benefits that have come to the medical fraternity as well should be expounded somewhere along the way, and how we've all come together as a urological fraternity around the world to exchange information, exchange data, and impact our services. Yeah.
Yeah, so they do mention on the article that the Zoom meetings promoted more attendance than actual physical meetings. So they saw a lot of people participating because of the Zoom meeting. So I do agree with you on that. It's definitely led to more information sharing. People are more comfortable on the Zoom meetings to attend all those meetings as opposed to a physical environment. So they do mention that on the actual article. So I do agree with you on that.
Thank you very much, Ryan. Thank you, Siyasanga. I think we're going to move to the last talk. We're a little bit short on time. Hopefully a slightly more light-hearted presentation by Dr. Kent Pluk.
Good morning, everybody. I hope you can hear and see me and my screen.
Thanks, Kent. You're a little bit soft there, perhaps a strong voice there.
Okay. Yeah, good morning, everybody. I assume you should be able to hear me now, Prof?
Yes, we can hear you.
Fantastic. All right. So far, fantastic talks. Thanks to everybody. Very interesting review articles. My talk, it's quite nice to end it off on something maybe a little bit more quirky, a little bit more lighthearted, which is a review article on the cannabis and male fertility, a systematic review, and this was published in the American Journal of Urology last year. Sorry. There we go. So just looking at the purpose and methodology of the study. So cannabis access, as we all know, and the usage in the US, and I think in the rest of the world as well, has recently increased due to legalization and the perceived benefits in chronic pain conditions specifically. So this study aimed to look at the effects on fertility, because we're all looking at the positive effects of cannabis. No one really is looking at what are the negative impacts of increased cannabis use. So they specifically, the authors specifically looked at three things, which was the reproductive hormone changes, altered semen parameters, and reduced libido and sexual performance. Like I said, this was a review article, and they looked at both animal and human studies and included both retrospective and prospective data. And in total, they chose about 48 studies. So let's just look at what they found in terms of the effects on sperm parameters. And they looked at multiple parameters, the first one being sperm count. And what they noticed there, that it seems to be an inverse relationship in that the increased, so it's dose dependent really. So there was one small study that they looked at, which they mentioned, it was only 20 patients. So most of these studies was really these small cohort studies. In the one study that they looked at, there was 20 patients, and these were patients all who were in essence cannabis users. And what they noticed was that the patients who smoked less than 10 per week had a much better sperm count. So the patients who smoked less than 10 per week had a sperm count of 68 million copies per mil, as compared to those who smoked more than 10 sort of marijuana cigarettes per week, and they were found to have only 26 million copies per mil. So not quite clinically oligospermic, but certainly reduced sperm counts. And so they really looking at a dose relationship. So the more you smoke, it seems to affect your sperm negatively. They also looked at the morphology, and what they found there, the one study that they mentioned was that patients certainly visiting the fertility clinic, when they asked these patients specifically about cannabis use, those patients who admitted to having cannabis use in the last year seem to have worse sperm morphology. And there they specifically looking at the EUA number of less than 4% of normal forms. Looking at motility, the reason this seems to be a scientific reason for easily explainable, explicable reason for the reduced motility, and that is that on the sperm itself there is a cannabinoid 1 receptor, and this seems to be where the problem lies, in that the marijuana, the cannabis actually affects this receptor and causes decreased mitochondrial activity. However, these were in vitro tests, so literally looking at test tube sperm, and not necessarily, this might not necessarily relate to clinical issues, because as we know, the testis, the sperm are protected by the blood testis barrier. So there is still quite, these studies are still early. There's no real big studies looking at in vivo, whether this will translate to an in vivo association. Then looking at the viability or sperm viability, one can see that there certainly seems to be a suppressed sperm viability. But once again, these were lab studies, and actually these were animal studies looking at rat sperms. And what they noticed there was that there was decreased viability of the sperm. But once again, this was looking at supraphysiological levels of cannabis in those test tubes. The last parameter they looked at was fertilization. And there what they noticed was that the sperm capacitation and activation seem to be affected. And so potentially cannabis use can be associated with fertilization, decreased fertilization potential. They also looked, like I said, at the effect on hormones. And what they noticed was that in terms of FSH, small studies actually failed to demonstrate a demonstrable, or failed to demonstrate an effect on FSH levels in humans. For luteinizing hormone, there certainly does seem to be a decreased level of luteinizing hormone, and this is possibly due to the CB1 receptor in the anterior pituitary. Just looking at that LH further, what they did notice, there was actually conflicting evidence. So most studies did show a decrease in LH, but then one or two other studies failed to replicate that. In terms of testosterone, what they noticed was that there may be a possible short-term effect on testosterone levels. But what seems to happen, what they noticed was that for patients who had not smoked for 3 months, it seems to recover fairly quickly. So it's really just at that time, if you smoked sort of within the last 24 to 48 hours or within the last week, it seems to affect your testosterone levels. But certainly your testosterone seems to recover quite rapidly. There was also an interesting study looking at testicular size. This was an animal study, unfortunately, where they did show that there was certainly atrophy in those rats when exposed to high doses of cannabis. And they actually mentioned that these rats were exposed to puffs of cannabis. I'm not sure exactly how they did that, but seems very interesting study to do. I hope it is only the rats that were exposed to the puffs and not the people conducting the study. Nonetheless, the reason that they postulate is that there might be effects on the oxidative stress effects on the seminiferous tubules. Lastly, like I said, they looked at the effects on sexual function as well, studies that looked at the effects on sexual function. And what they found was that some studies show that in humans, at least, cannabis, because of its sort of effect on the mind and mind-altering effects, it may actually improve desire in the studies that they looked at, which is in contrast to results in animal models where they found that rats exposed to cannabis seemed to be more docile, and there was, in the one study that actually mentioned, less humping in that cohort. And as far as erectile function goes, it seems that there's sort of paradoxical effect here in terms of sexual function, because certainly it seems that in both humans and animal studies, there seems to be a diminished erectile function, especially acutely, and this is due to the impaired neuronal nitric oxide synthase activation. So while there may be increased libido, there might be a negative impact on erectile function. So, those two, unfortunately, paradoxical. So in conclusion, the strongest current evidence shows that there may be deleterious effects on sperm parameters mainly, because that seems to be where most of the research was done. There's paucity of high quality data, and most of these are in fact animal models, in vitro studies of endogenous cannabinoid compounds and retrospective analyses. There doesn't seem to be any large big studies, prospective studies on humans. Physicians should consider probing cannabis use in evaluations of male infertility. And of course, when considering putting patients or prescribing medical marijuana, one certainly needs to be cognizant of the fact that it may affect their fertility. What I did was also, I just looked at, because what the study doesn't look at really is, like I said, looking at epidemiological evidence of whether there is really an association between cannabis use and the direct, whether it really does affect fertility on a more sort of on a real world level. There are a few studies, and the two large epidemiological studies that I found. One was the Presto study. This is in the Journal of Epidemiology, and they looked at 4,200 couples, which were these are just regular couples who were sort of having regular intercourse and not necessarily infertile. So these are just regular couples, epidemiological study, 4,200 people. And they then asked these couples whether they used cannabis or not. And what they found was that then they looked at these couples a year later and how many of them conceived. And what they found is there was no difference between those who had used cannabis and those who didn't. So in real world terms, it doesn't seem to be, the epidemiologists at least, don't think that there may be an association, a real world association between casual cannabis use and fertility in terms of couples. And then there was another study I looked at, which was from Harvard, in fact, at the Massachusetts General Hospital. And these were looking at patients who were attending fertility clinics. So not just general population, specifically patients who were attending fertility clinics. And there, once again, they failed to show a direct association between patients who were using cannabis and fertility. What they did, however, find was that females who admitted to using cannabis had higher rates of losing their pregnancies. These were patients now at fertility clinics. So patients who were on ART, they had a twofold increased risk of losing their pregnancy if they were using cannabis. So that's quite interesting to find. And that's the end of my talk.
Thanks, Kent. There was more to that article than I had thought. The idea that the sperm actually has a cannabis receptor is a fascinating concept that might reduce sperm motility. Dr. Corley has said, seems unbelievable people actually spend time working, giving Zol to rats and watching them hump. I think I need a new job, he says. Kent, thank you very much. I don't see any other hands, and we're just a little bit over time. So thank you for all the participants and those who commented. And Lisa has quite rightly said, I would love to see the animal ethics application for that study.
Making them happy, perhaps. Happy rats. All right.
All right. Thanks, everybody. See you next week.
Thanks, everybody. Ciao.
Bye.